Okay, well, I'd like to welcome everybody to Pediatric Grand Rounds and turn this over to our Vice Chair for Education, Dr. Sandrine Van Schaik, to introduce our speaker for today.
Welcome, everybody. It's my great pleasure to welcome today our speaker, Dr. Robert Pantel. If the name sounds familiar, yes, indeed, he is related to Met Pantel, one of our faculty in the Department of Pediatrics. Dr. Pantel is a professor emeritus of pediatrics at UCSF. He grew up in New York City. After graduating from Columbia, he received his MD from Boston University and completed pediatric residency in Chapel Hill and fellowship at Stanford in health services research. He spent several years working in the migrant farm workers health system in Idaho and teaching at the Medical University of South Carolina before spending a 30-year career at UCSF, where he led the Division of General Pediatrics for over 2 decades and developed a joint academic general pediatrics fellowship with Stanford. His research focused on doctor-patient communication, quality improvement, and febrile infants. For the past 7.5 years, he directed the Kapiolani Child Advocacy and Protection Center in Hawaii. And when I read this bio, I thought maybe I should actually put a map up because you've been all over the place. And that must give you a very broad perspective of how medicine is practiced across the United States. We always ask our speakers to tell us, like, how did you become passionate about this topic? And Dr. Pantel said, I became passionate about this topic in the early 70s when he perceived the emerging trend of doing complete sepsis workshops on all infants that was not based on science, but the need for chief residents to sleep at night. And I think that's still the case, that chief residents want to sleep at night. So I'd love to hear more about your current perceptions and ideas around sepsis workup and fever in febrile infants, and I'll hand it over to you, Dr. Pantel.
Again, and to have this opportunity to speak to some old friends who are still around. One of the things will be doing at this presentation is, since I've presented this a number of times in the past, including at San Francisco General, is I'm doing a somewhat different presentation. I'm actually expanding it a little bit beyond the fever guideline that was published back in August of 2021. So topic today, I'm really talking about looking under the hood of the AAP guideline. And this is for well-appearing febrile infants, and it's for under 60 days. The guideline, as I say, is published in pediatrics, and the development of the guideline is published in hospital pediatrics. So I'm certainly not going to be repeating everything that many of you have already read. I'm going to try to touch on some of the highlights and some of the questions that have emerged since the publication. Also, I put my email up. I get frequent questions from all around the country. I'm certainly happy to answer questions by email. And since I'm in town, anyone who buys me a cup of coffee, I'm happy to talk to you face to face. So I have no relevant disclosures, and I won't discuss any unapproved commercial products. I also am not going to even discuss any of the antimicrobials. We had a group of 5 infectious disease people on our committee coming up with those recommendations. So I'm going to say they are neither right nor wrong, but they are official, and I'm not going to delve into antibiotics. So I wanted to really start out by talking about a tale of 2 timelines. And these are 2 different guidelines in which UCSF had a major role in the development, and I had a partial role in the development. The first guideline has to do with perinatal HIV screening. And at that, this was still early in the epidemic. Drugs had just been developed. There was tremendous perinatal transmission. UCSF had one of the first programs in perinatal HIV at San Francisco General and was a participant in AIDS clinical trial group 076. I happened to be on the AAP's HIV committee at the time, and on February 18th of 94, the code was broken in a randomized controlled clinical trial of AZT given perinatally and postnatally for several weeks, and found out the perinatal transmission rate was dramatically different, 25.5% versus 8.3%. What was interesting is a task force was immediately convened by the United States Public Health Service, and a meeting was held a few weeks later on June 6th. There's probably 1,000 people there. CDC was represented, NIH was represented, NIAID, and Tony Fauci was there before he became a public figure. And there was tremendous debate because at the time there was tremendous stigmatization over HIV. There were concerns raised about whether we had routine perinatal screening. Women would be discouraged from coming in to see their OBs. There was concern that if we had universal screening of pregnant women, would this be a slippery slope and everybody would be required to be HIV tested. Anyhow, at that meeting, I happened to be on a subcommittee looking at the specific question of universal perinatal HIV screening. There are lots and lots of other questions. So this is a subcommittee of 9 people. Surprisingly, the vote was a narrow vote of 5-4 for your universal perinatal HIV screening. In addition to myself, there was a representative from the UCSF School of Nursing who was very involved with the perinatal care of women. A few months later, the official recommendation came out in MMWR, and it was actually a few months after that that New England Journal of Medicine published the results. So what we have is literally less than 6 months from the release of information on a study to a universal recommendation for HIV screening. Moving right along, let's talk about the evaluation of febrile infants. I need to thank my daughter for creating these slides for me. At the top is the birth of the United States, actually going from the Declaration of Independence to ratification of the Constitution by all 13 states. In fact, from the beginning of the Constitutional Convention, the writing was finished in about 1.5 years, and it was ratified by 9 of the 13 states in under 2 years. So that was one example of developing policy. On the other hand, the AAP guideline actually took 16 years. And I'll get into a little bit about why it actually took that long. So I wanted to start now with the journey it has taken to get to the guideline. And I also want to say at the beginning, and we'll probably say at the end, that this is not the final word on this topic. This is what we feel is the beginning of a journey in which we hope comparative effectiveness research is going to lead to even better and better guidelines and recommendations. So the starting point really was in the early 1970s when Group E beta strep really roared back. It had not been seen for a while, and suddenly all of these infants were turning up with Group E strep septicemia, Group E strep meningitis going out 2 weeks, 4 weeks, 6 weeks, and there was tremendous concern about that. We were behaving at that time the way we always behaved, which is if somebody looked sick, we evaluated them. But then 1976, Paul McCarthy came out with some interesting data pointing out to how high fever was a very, very serious concern, and that children with temperature of 40 or greater, about 1/3 of them had what they called serious bacterial illness, which included bacteremia, included meningitis, but other things such as pneumonia. Again, we sort of went along clinically until Ken Roberts, who is my co-author and great supporter in this document. It's as much, if not more, his than mine. He came out with this publication and something I'm sure you all get, which is the Johns Hopkins Medical Journal. One of the reasons it didn't appear in a major journal is I don't think fever was a big topic back then. But what he noted was that 8 of their 9 senior residents actually, excuse me, of their senior residents, only 8 of 9 infants with bacteremia were actually detected. That one of the infants looked well, and one of the infants had a perfectly normal white count. And this was an oh my God, what are we going to do? We will miss infants on a clinical basis. And this is one of the strong launching points for complete sepsis workups on all infants. As time went on, I was also interested in this in the late 70s. And I took a look at nearly 1,000 infants in a facility in South Carolina I was working on at the time. And the number one diagnosis was well child. That was over 60% of the cases. And that is actually because what we were doing at the time is every infant that came into the clinic had a temperature taken. And so most of the temperatures greater than 38 weren't even noticed by the clinicians who were really there to do well child exams. And one of the things I argued, since it was about 10% of all infants being seen in the clinic had fevers greater than 38. It's like, are we really going to do sepsis workups on 10% of our infants? I thought probably not. 1983, Kathy DeAngelis came up with a landmark paper, said, hey folks, there are iatrogenic risks and financial costs. There's lots of IV infiltration. There was even one child that was kidnapped from the hospital by a patient who escaped from the Hopkins psych ward. So there really are consequences, iatrogenic consequences of hospitalization. The 80s were really consumed with many attempts at trying to separate out high from low risk infants. And they started out initially looking for who is high risk, but then the Rochester group came up with the Rochester criteria, in which they try to identify infants at low risk as opposed to infants at high risk. That became known as the Rochester criteria, obviously. What was interesting about the Rochester criteria is, unlike all of the other guidelines that were not so much guidelines, but decision models, unlike all of the rest that relied on white counts and clinical appearance and urines and LPs, the Rochester criteria did not require cerebrospinal fluid analysis. Time marched on, and in 1993, something that became known as the Barrett guidelines was not really an official guideline committee. It was just a group of very smart people got together, and they came up with a series of recommendations. And those recommendations have pretty much been the backbone of what people have been doing, although we do know that most people don't even bother to follow guidelines. What they really said is that you need to do a complete sepsis workup on everybody under 28 days. But for 28 to 90 days, you had some options. And as long as you got a blood culture and a urine culture and a cerebrospinal fluid culture, if the preliminary lab tests were negative, you could give ceftriaxone to all of those children and send them home overnight, with the caveat that they needed to be back in 24 hours, and also with the caveat that you had enough confidence in the family that there was a pretty good chance that they would be back in 24 hours. So that was sort of the prevailing model throughout the 90s and moving forward. There have been numerous studies that show that physicians don't follow guidelines, but nevertheless, that was, what was supposed to have been done back then. And now let's turn to a study that has a heavy influence from UCSF. Most of the authors on this JAMA paper are UCSF faculty member, Tom Newman, who's premier epidemiologist and UC faculty, who is enormously helpful with this, as well as John Takayama, who's still here, and Dave Bergman, who deserted and went down to Stanford. anyhow, what this was really the first large national study done of febrile infants. All of the other studies had come from the emergency departments of Boston or Yale or Milwaukee or New York. They were all inner city emergency departments. This was a large study. We had 43 states, we had 567 pediatricians, and we had 3,066 infants enrolled in this study. So what did we learn from the PROS study? This is the AAP's Pediatric Research and Office Settings Network. What did we learn from the febrile infant studies? Well, you can see in the youngest infants had the highest rate of what's now known as invasive bacterial infection or Bacteremia and bacterial meningitis, 4.1% of the infants. Second month, 1.9%, and the third month down to 0.7%. And I think these numbers are large enough and clear enough for you all to see what's going on. Well, let's look at the bottom. So we had 63 infants, and they were treated in all sorts of different fashions. Hardly anybody paid attention to guidelines. I'll tell you about that in a minute. But what happened? Well, I'll tell you about that now. If we compared it to the BARF guidelines at the time, this group did 1,000 fewer LPs and hospitalized 1,000 fewer children than had they adhered to the BARF guidelines. So again, these were community practitioners all across the United States. Well, how do they do in these 63 infants? Well, it turns out that they treated with appropriate antibiotics 62 of the 63 infants. So this is remarkable. This is an over 97% sensitivity, which is actually better than any of the previous guidelines. Well, that's kind of interesting. But how do you translate this? What are the implementation points in this? And I had been belaboring this, and one evening, my wife came in and she sort of looked at all the papers across the table, and I started talking about risk ratios and odd ratios and sensitivity and positive predictivity and on and on. And she came up with an interesting statement, which is, if you want odds, go to Vegas. If you want God, go to church. If you want good clinical care, go to a good clinician. She's on the School of Nursing faculty at the time, and actually still is. Well, the trouble with go to a good clinician is we had 573 or 76 pediatricians, and we just didn't see how everybody in America could go see those 573 pediatricians. So I'll come back to you a little later and say, well, what did we do with all this data that we had? Well, after that was published, it was interesting because we showed that pediatricians were doing a pretty good job. We even made some recommendations, which I will get to. But pediatricians were still being chastised for not adhering to the BARF guidelines. And this is the actual email that Mort Wasserman, who was head of the PROS network at the time, sent to the Academy and said, hey, we did this big study, had a lot of grant money from AHRQ, we had a lot of support from the Academy, and people aren't paying attention to it. Maybe what we need is an official AAP guideline that says, and highlighted in green, is that one that it's not one size fits all. And that was actually the launch of the process for the pediatric AAP pediatric guideline for febrile infants. So let's talk about the process, because I think it's important to understand the good as well as the bad about the process. So I think we did a good job, or the AP did a good job in getting different viewpoints. We had representatives from pediatric primary care, family medicine, emergency medicine, both pediatric trained physicians and adult physicians who often see children in adult EDs, pediatric hospitals, pediatric infectious disease. We had an excellent epidemiologist, someone whose career was focused on algorithm development, another person involved in the Academy's quality improvement projects. It was also interesting for the pediatric primary care. We actually picked the PROS pediatrician who had contributed the most number of febrile infants to the study. So we wanted somebody who was really quite good at this. I think he was in rural Washington state and saw something like 30 odd infants in his office during the study period. This is actually the names of the people. Many of them are recognizable to people here. Nate Cooperman, who's actually the head of the PCARE network, is Pediatric Emergency Care Research Network. Gary Byington, who is leading the Utah approach and is now vice president for UC Health. So this is really a very, very experienced group. So we had to start out deciding who's going to be in this, who are we addressing. These are the eligibility criteria. This is for well-appearing children. Anyone who really looked moderately or seriously ill deserves the traditional workup. The temperature had to be 38 degrees and it had to be documented at home or at the clinical site on arrival. These are full-term infants, and we decided to stay away from the early neonates the first week of life because the rate was so high and it was a different set of organisms. There already was a guideline. Excluded, obviously, were obvious perinatal fevers of the mother, a high suspicion of HSV, bronchiolitis, serious medical conditions, or immunizations past 48 hours for older children. Excuse me. We allowed infants with URI to be included, diarrhea, otitis, and positive viral tests. Also, we said who should be included are parents. And this is where we are today when appropriate parents' values and preferences should be incorporated as part of shared decision-making. And there's a lot being written about that today, and Paul Aronson at Yale is written extensively about this and even has some guidelines available for helping with shared decision making. For each age group, we had a structured approach in terms of evaluation, what the initial treatment should be, and crucially, whether there should be further management in the hospital or at home, as well as the duration of treatment. So first thing we had to do is assemble the evidence. Well, we were helped initially by systematic review by AHRQ, but it took a long time for them to get that to us. By the time they got it to us, the information was already out of date. So we had ongoing review by the committee, by our epidemiologists. The other thing that we did that was unusual for most guidelines is often when articles are published, you're left with a question. Well, I really want to know X, and they only talk about Y. So what we did is we just contacted authors, and almost all the authors we contacted were willing to go back to the data that was the basis of their peer-reviewed publication and run additional analyses for us to help answer questions. And all of these thanks are in the guideline. Borja Gomez, Spain was very helpful, as was Tara Greenhow at Kaiser Northern California. But we had unique cooperation in developing the best evidence that we could. We then had to compile the results. Well, the first thing we decided to do is look at the old SBI classification. This is actually from a 2016 paper by Tara Greenhow using Northern California data. And I think what you can say is UTI just absolutely overwhelms bacteremia and meningitis. And it made no sense for us to have a heterogeneous variable, quote, SBI, when one condition overwhelmed the other, not to mention the fact that there is such a difference in morbidity and mortality between UTI and meningitis that it just frankly seemed silly. And so one of the things we felt strongly about is that we're going to get away from that. We put that in the guideline. People still ignore it because people ignore guidelines. But we don't. We really think they should be looked at individually. The other thing about UTI is the latest data shows that a urine dipstick has a sensitivity exceeding 98% with the specificity exceeding 90%. So that's not the challenge. You can figure out a UTI pretty quickly. It's bacteremia and meningitis that are the challenge, and that's the challenge that we addressed. So we said, well, let's determine the prevalence of meningitis. That's important. Well, it's important, but it's also problematic. This is again from Northern California Kaiser, Tara Greenhow, December 2016 pediatrics. So let's look at the red circles. Well, the circle on the left is based on CSF cultures. Of all the children who had cultures, 1.2% had bacterial meningitis. So if you're asking the question, how many LPs do you need to do to pick up that last case of meningitis? It's 83. Or if it was 1%, it would be, you have to do 100 to find that last 1%. But if you take a look at all of the febrile infants, wow, it's only 2 of 625. That's down to 0.3%. So now it's like 313. We want to do 313 LPs to detect the last case of meningitis. And this is where some of the debate in the committee came up. We'll also take a look above the red circles at the 7 to 28 day age group. What's interesting is that 38.5% of this age group did not have CSFs obtained. So again, this is the 2015 approach to the 93 BARF guidelines. Clinicians just are not following the guidelines. Well, after struggling with meningitis, and you'll notice that we did not publish graphs on that, we try to determine the prevalence of bacteremia. And here we did a little bit better. These are combined studies from the PROS study, the AAP Collaborative Research Network, PCARN, which is the Pediatric Emergency Care Network, the Intermountain Healthcare out of Utah and other northwestern states, as what we also did at the end is combine them, which might make some statisticians shudder, but we did it anyhow. This represents probably 15 to 20,000 infants. And so we had reasonable confidence that we were getting somewhere near accurate prevalences. And I think what you can see in the combined group is the different prevalence in each of the age group. And this is in part what drew us to the decision to pull 22 to 28 days out of the 8 to 21 day group. It's not as low as the 30 to 60 group, which is not as low as the 60 and greater group, but it's a decision we made. So now the first study I talked about, really the first line here applies to that. If the evidence is of high quality, it will speak for itself. And it really did speak for itself in HIV perinatal screening. However, let's look at fever. Problem here is we feel that evidence alone never speaks for itself or conveys the truth because it always requires interpretation. So let's talk about interpretation for a couple of minutes. Well, again, we said is a number is not a decision. It's a starting point. Okay, so let's take a look at the evidence now. So to identify one well-appearing infant with bacterial meningitis, how many LPs are you willing to do? this was a question that I circulated to our committee, which at the time had 13 members, and I said, this is blind, just answer the question, 50, 100, 500, 1,000. At that point in time, one of the committee members looked at me and said, why are you stopping at 1,000? Why aren't you going considerably higher? I think that indicates the variability, and there is tremendous variability on our committee. Now, one might guess that the most conservative group would be the infectious disease experts, whereas perhaps the primary care group would be would not be as conservative, would look like the Northern California Kaiser group. In fact, much to my surprise, and perhaps to yours as well, is that the two polls were anchored by infectious disease specialists. Not only that, but both of these individuals had been chairs of the AAP's Committee on Infectious Disease, or the Red Book Committee. So again, the widest variability were on two of the people who chaired the Red Book Committee. And I think that gives you an idea of just how important risk tolerance is. So here's the question. How high is high? How high is too high? And who decides? And I wanted to illustrate this by something out of my childhood back in New York when we were in a picnic in 1953. And at that picnic, my little brother is a year and a half at the time, and my favorite uncle, Uncle Ned, was there, and he was playing with my brother, and this is what occurred. Well, there's Uncle Ned, and this is what Uncle Ned was doing with my brother at the time, so that's how Ned saw it. The next column is how my brother Rick probably saw it. And judging from her reaction, this is how my mom saw my Uncle Ned throwing my brother into the air. So in addition to that type of perspective, there's different perspectives and experiences based on who you are. Are you a community-based pediatrician, where you're seeing, again, the right-handed column in Northern California Kaiser? Are you an ED pediatrician, where you're seeing a select group, perhaps only the high-risk children in your community? Or you may be an ED pediatrician that routinely just sees all of these kids because people just don't want to do them. They might need to do ED, and that's very common these days. There's also a difference, perhaps if you're a family physician, if you're a hospitalist, you're ID specialist. So these are some of the things that we felt we needed to be explicitly aware of as we march through our guideline. Also, a lot of assessment challenges, and this is an important one. Remember, I'm saying this is for well-appearing infants. Well, how do you judge well appearance? And are you going to be better at judging well appearance if you're a pediatrician with 30 years of experience, or if you're an adult ED physician seeing a child and you're a year out of residency? Compounding that is the fact that pediatricians are often looking for social smiles. At least that's something I know I do. And here's a nice graph on when the social smile predictably comes in. And it really doesn't predictably come in until about 6 months of age. So you're pretty stuck very often in well-appearing children. I also bring this up because some studies have used the Yale observational score to sort well from ill children. That's a very nice, thoughtfully developed scale that really does not apply to younger infants. It was developed in the era of a tremendous amount of pneumococcal bacteremia, and it works reasonably well in infants over the 6 months of age, and it's been shown repeatedly not to work at all in very young infants. So be wary of studies that rely on the Yale observational scale, and remember this slide. This is at our first meeting, and this is my excellent artwork. This is not the final algorithm. We had a person who specialized in algorithm, who actually kept a record of all of the algorithms developed. And as you can see, we had 189 different algorithms that we debated over the years to come to the final algorithm that appeared in pediatrics. Now, remember this process, we had to reach consensus. And I wanted to pause here because there were several points in which we had narrow margins. There was a 7-6 margin on issues in the 22 to 28 day group that I will discuss. The Academy wisely decided that they would not go with simple majorities because you could run into some of the problems of our Supreme Court, but they would use the consensus model that gave us the US Constitution originally, which is 9 of 13, or more than just a simple majority. And what they did is they added 4 more people to our committee. 3 of them happen to be infectious disease people, but that's okay. Anyhow, after we finally reached consensus, we had to submit the draft for review. It went to 6 AAP committees, a council, 6 AAP sections, 3 other AAP groups, 3 external organizations, including a parents group. We also had parents giving us feedback during the development of the guideline. And then we had to respond to over 1,000 comments, many of which were in the exact opposite direction. So that was a formidable task and added some time to the process. And then finally had to be reviewed by the senior vice president of the Academy, who would then send it to the board of directors, and they had their questions. And finally, we come to the guideline itself. I'm just going to hit a few highlights. For 8 to 21 days, based on the bacteremia rate, based on the meningitis rate, we decided we are not changing a thing. We strongly recommend complete sepsis workups for all infants in this age group. There's one thing that we changed a little bit, and that we say, rather than hospitalize all, that you should actively monitor in a hospital, in a facility with nurses and staff experienced in the care of neonates and young infants. And in some cases, an experienced parent may be the best place for a child to be overnight. As an example, this is Molokai General Hospital. This is on the island, obviously, of Molokai. It is an excellent 23-bed hospital. They refer patients to us all the time. They just don't have the clinical experience to take care of potentially very ill young infants. So this is the type of situation, and you all, and we assume pediatricians across the country very well know their local circumstances and when they should perhaps send a child home with an experienced mom, perhaps send a child directly to a regional hospital. But that is an important differentiation. Most of the discussion, the debate, and the need for increasing the committee side came from this group, 22 to 28 day old. So let's take a look at what we're saying there. Well, as in all age groups, what's uniform for the guidelines is we want you to obtain urine specimens, we want you to obtain blood cultures, and what about inflammatory markers? Okay, inflammatory markers are actually sort of optional in the first group because you're going to hospitalize everybody and treat everybody anyhow, but so it won't determine that, but it may be helpful down the line in distinguishing whether you're looking at a contaminant or positive organism. Excuse me. So this is what's in print. Where did it come from? I'll show you in a minute. The abnormal inflammatory markers are temperature greater than 38.5, absolute neutrophil count greater than 4,000. We have 2 different numbers because they were derived from 2 different studies. CRP is just a convenient number that's been used frequently, but it was not derived. It was something that's been tested. And procalcitonin is a number that was derived. So let's take a look at how did we get these numbers? Well, most of you have seen these curves. They were under the receiver operating curves and tells you how good a test is. A perfect test would be 1.0 would be 100% sensitivity, 100% specificity. Never seen it. But the closer you get to that, the greater the area under the curve and the better the test. It's a nice study by Millicent in France, pretty much nailing what we know in younger infants, and that procalcitonin is better than CRP, it's better than ANC, and white count is not particularly helpful. The ANC is much better. So this is a small study. This is 24 cases, but suggested that if you only had one test to take to a remote island, you might ask for procalcitonin. CRP, and remember this is now available as a point of care test, and we'll come back to CRP in a minute. So this is from the PROS study, and I'll make it easier to see. Again, since we couldn't send everyone to the 563 pediatricians, we used a technique called recursive partitioning analysis to see what is the best decision rule we could come up with. In the past, people used decision models, which is you pick things that make sense, like a white count over 10,000. That makes sense. Let's use that. This is, well, let's let the computer tell us what the best numbers are and what the best predictors are. So you throw everything into the computer, and the computer says, all right, what's the best variable that will distinguish high and low risk infants? And we did that. And we had 3,066 infants. We had 66 with bacteremia or bacterial meningitis. We had complete data on 63. And the first cut was, no surprise, moderate illness, moderate or very ill kids. Well, that was 36 out of the 63. Pretty darn good. All right, well, what about the other 27? Computer then says, okay, the younger infants had a higher rate, get 13 more, or 3.4% versus 0.8%. So that's a pretty good high risk low. Well, let's keep going. All right, and that's where temperature greater than 38.5 came from. And then, oh, look at this, temperature greater than 38.5, 1.2% versus only 0.4%. Now, somebody's probably remembering from an earlier slide, well, wait a second. Pediatricians, only missed one. How come you missed 4 with the model? And that's, again, because pediatricians have dozens of factors to look at. Actually, the ANC on one of these children was 12,000, which is elevated in almost any other algorithm. The one bacterial meningitis miss was very interesting in that this is a well-appearing child. This is a well-appearing child who had a completely negative CSF, did have an elevated ANC. However, that physician decided to send the child home. The child got sicker in the next 6 or 7 hours. Mom headed back to the hospital. Within 12 hours, the blood grew pneumococcus and the CSF grew pneumococcus. That child would have been treated immediately had pediatrician looked at the absolute neutrophil count. This was a 28-day-old. But it also reminds us that we probably, not this year, will not get to 100% sensitivity and specificity. We may with the next generation of biomarkers, however. Moving right along, ANC and PCT comes from the work of the PCARN group. And this is a study by Nate Cooperman and colleagues. They had 30 infants, and they did the same thing. Again, they did not, they used the Yale observational scale, so they don't have clinical appearance on the top. They have positive urinalysis on the top. This is where the ANC comes from, and this is where the procalcitonin comes from. For some reason, they rounded down because they thought it would be easier for pediatricians to remember that, but this is actually their recursive partitioning analysis, and they had only one miss out of 1,017 infants, excellent sensitivity, 97%. And, everybody is very happy with that. Well, one thing though, the hallmark of science is replication. And this is a replication study that appeared the following year out of this, the Spain ED group. They had 38 cases. And if you go to the bottom right corner, it's whoops, they missed 5 of the 38 cases. So what's going on here? Well, again, it's a different population. You're going to get different results depending on whether you have predominance of E. coli or whether you have predominance of group E strep. The one thing about the 5 missed cases, though, is 2 of them were under 14 days, so they wouldn't have missed by the AAP guideline. And the other 3, it's interesting, all 3 had temperatures of 39 or greater. So again, they would have been picked up by the AAP guideline. 2 of those 3 had CRPs greater than 20. So again, they would have been picked up by the AAP guideline. So I think the AAP guideline is more conservative than the PCARN rule, and is something you ought to think about. I have had a sneak peek at one study, which is looking at how the performance of the AAP febrile guideline is going, and it's looking pretty good. Also, the AAP revised 2 is a study of hospitalists that is up and running now. We'll look at just how good a job we did. This was a Spanish validation study I just talked about. Interestingly enough, the best performance was by procalcitonin alone. The next best was by CRP alone. And the PCARN rule came in number 3. So it may be that some of our biomarkers are doing a pretty good job. I'm going to skip now. The other big controversy was, did you need to do an LP or not? And the answer is that you should if it's positive, and you also should if you're going to send a child home. If, however, a child is being hospitalized and being observed in an experienced facility, you may hold off on an LP. So that again is a difference from the old BARF guidelines. And then in terms of antimicrobials, again, if the child's in the hospitals, there's an option of just observing the child without antimicrobials. However, if you're sending a 25-day home, you should manage them at home. Again, they've had a negative LP, and this is in concordance with the BARF guidelines. Again, an important point is you should hospitalize infants if the CSF is not obtained or is uninterpretable. Also, there has been some confusion about can you send an infant home with any positive IM? I think our conservative approach is no. You really need to keep infants in the hospital if they have a positive IM. 29 to 60 days, that pretty much is get a urine, get a blood culture. If the urine is positive, you can treat that child with PO as an option. If anything is positive, again, you may consider hospitalization. This is an older age group. It's not all that complicated. It can be summarized in one 3x5-inch card. So just summarizing now and applying the guideline, the first thing is that it does not indicate an exclusive course of action. We are encouraging variations. And one of the reasons for encouraging variations is, again, this guideline is a starting point. And I think the next iteration is going to be practice variation studies by different groups doing things slightly differently. And I have a couple of examples. This is what we're doing now in Kapiolani. This is our last week's iteration of the guideline. The top bar indicates there are things you need to do on all age groups, so it makes it easy for nurses to know what to do when the child hits the clinic. This is by Andy Marmer over at the General, and I really like this because she has all these arrows in terms of options and alternate pathways. We like these tweaking of guidelines. So in summary, here are the take-home points. We encourage you to abandon SBI and consider each of these bacterial infections separately. We're now grouping infants by month, and we've created an intermediate group, the 22 to 28 day group. We don't think you need to get LPs on everybody. People didn't need our permission to do this, as you saw from the Northern California Kaiser data, but we feel that there's, this is a May issue. In terms of hospitalizing all, we also want you to consider when observation or treatment at home is appropriate, and in some cases may even be better. I did not dwell on this, but current laboratory techniques are good, and we think 24 to 36 hours are sufficient. You are still going to have, and some pathogens will grow after 24 hours, and even a few after 36 hours. But in general, 24 to 36 hours should be sufficient. And again, a reminder, this is not an exclusive course of action. So what's the bottom line? Well, in guidelines, what we're really trying to do is teach you about driving safely in a multi-lane highway. This is provided to keep you from driving off the road. However, if you're a physician in a room with a patient, we encourage you to take into account all of the individual circumstances. For example, our study revealed that if there's other illnesses at home, it lowers your risk of having invasive bacterial infection. On the other hand, while the Yale observational scale did not work, an infant with a high-pitched cry is at much higher risk. So there's lots and lots of variables. There's also variables in terms of time and place. Would you treat a child differently, seeing the child Tuesday morning? How about if you're seeing a child at 4:45 in the afternoon on a Friday at the beginning of a 3-day weekend? So we really want individual physicians to consider individual circumstances. And by that, we hope to get, and this is a phrase my son Matt came up with, we'd like to get to the point of having one patient, one guideline. So to end, this is the beginning of some of my deeper studies. On the left is Matt when he was a lot cuter and had a lot less hair. Next to Matt is my favorite son, Gregory. And next to Gregory is my favorite daughter, for whom I ignored guidelines when she had a fever at age 2. Anyhow, I'll now open for questions. Thank you very much.
Thank you so much, Dr. Pantel. I don't actually know if Matt is in the audience, and I want to make sure that he has an opportunity to respond to your last comments there. And it's a very cute picture.
Yeah, he's come to accept that.
I totally appreciate that. I don't know if there's any questions. I don't see any questions in the Q&A, but maybe in the meantime, I'll take the opportunity to ask a question. I really appreciated the picture to demonstrate how different people perceive risk differently. I think it was your brother being thrown in the air by his uncle, and how the mom thinks it's like really high up, and the kid itself thinks it's somewhat high up, and I'm wondering whether you actually, because these guidelines seem to be changing, and in this day and age, parents get a lot of information from the internet. And so do you have any recommendations on how to navigate this changing guidelines issue with parents, as they might have read something or seen something and are like, well, we don't want the new guidelines, we want the old guidelines?
Yeah. Well, I mean, you bring up a very, very challenging point. I mean, I think one of the biggest differences, at least something I've experienced personally, is what I consider high risk and what the patient considers high risk. And I ran into this many years ago with a febrile infant, where I was talking about what I considered a high risk of bacteremia of about 3%. And the parent said, oh, 97% child's feeling fine. I'm out of here. And, you know, at least this was a family where I felt I could get good follow-up. I had good rapport with them. I did not sleep well at night, but we're going to run into that continually. I'm also reminded of a friend. This is 20 odd years ago when there was more of a strong feeling of everyone should do everything. He happened to be in solo practice. I was visiting him in New York, and he kept excusing himself and making a phone call. And he was doing this pretty much every hour on the hour. And I said, what's going on? He says, I sent home, you know, a 5-week-old with a fever, and I'm checking on this child. And he called this child, this parent, you know, every hour on the hour until about 11 o'clock. And I said, you've had too many drinks and it's time to go to bed. So, I mean, there's a lot of different approaches. And I'm not suggesting everyone call every parent at home every hour on the hour, but, you know, you need to take into account those differences in perspective and thresholds. I think the best thing we could do is sort of look at the current data, have the best sense we can, be as honest as we can with families, let them know some of the risks. And if, you know, they want to do something that's we consider is not driving off the side of the road, try to come up with the best set of accommodations as possible. Well, if you want to go home, then you do really need to talk to me in 2 hours, and you do need to show up at 7 o'clock in the morning.
Fair enough. I totally love the illustrative example there as well. I don't see any other questions. I have one more sort of more of an observation that maybe you can comment on. The residency requirements and the exposure to different experiences are changing, but it is still a requirement that all pediatric residents learn how to do lumbar puncture. With changing guidelines, they get less and less exposure to that. And I'm wondering, that might actually have really big implications for the competency of providers in doing lumbar puncture.
That's a very good and interesting point, because when we started looking at some of the current data on LPs, the miss rate was extraordinary. The bloody tap rate was extraordinary. The contamination rate in several studies is over 90%. And people on the committee, because a lot of people trained in the 60s the way I did, and before pneumococcal vaccine, before Haemophilus vaccine, before GBS screening, and we were just doing LPs all the time. And yeah, we missed some, and yeah, we got bloody taps, but we had a lot of experience. And one of the people on the committee even said, the way things are going now, an LP might become an interventional radiology procedure in a few years. And maybe that will be a good thing. I'm not sure, but you're absolutely right that experience has everything to do with day-by-day management, which is again why we sort of have a guideline where we acknowledge that experienced pediatricians are different than adult ED physicians seeing a child in the ED. It's experience related, and we encourage people, if they don't have enough experience to judge that a child is, quote, well appearing, to go ahead and do the full sepsis workup. I also used to remind people that the PROS study, and this is before a lot of other studies emerged, the average age of the pediatrician there was 45 years of age. So this was an experienced group of pediatricians, and no disrespect to my audience, I also would say this is not for interns in July. So I think interns in July would probably be well to either talk to a 45-year-old pediatrician or to go ahead, if it's the middle of the night, and do the complete sepsis workup.
Thank you so much. I'm going to leave it up to Dr. Hirsch to close it up for us today.
Thank you, Sandrain, and thank you, Dr. Pantel, for a wonderful grand rounds. Very interesting and informative, and it's really nice to know that the Pantel family is continuing its legacy in our Department of Pediatrics at UCSF. And although Matt might not be your favorite son. He's our favorite son amongst the Pantels at this point. Wish everybody a good rest of your week, and we'll see you all at the next grand rounds.
Good. That'll help his ego. Thank you.